A very good evening to everyone, all the delegates who have joined today with us. On behalf of Intas Pharmaceuticals and the Zenith Division, I, Dr. Mohit Changani, would like to welcome you all. After conducting 8 successful events, here we are today with the 9th edition. Today, we have a great program lined up. We have today with us a renowned personality who needs no introduction. He is the course director for us today for this series. He is Dr. J.C. Mohan. If I tell something in brief about him, Dr. J.C. Mohan is a chairman and head of the Department of Cardiology at Jaipur Golden Hospital, New Delhi. He has published more than 250 research papers in various index journals. He is the only honorary fellow of the American Society of Echocardiography in India. Currently, he is the president of Apex Society for CME in Cardiology. He is the recipient of Sujoy B. Roy Gold Medal by the Cardiological Society of India, Cyril Award for Best Research Paper by the Cardiological Society of India 1988, and the Health Minister's Award for Meritorious Services. So we are so very glad to have you here, Dr. Mohan sir. And now, without doing any further ado, I'd like to hand over the session to Dr. J.C. Mohan, and would like to request him for the further proceedings for this program. Dr. Mohan sir.
Thank you, Dr. Mohit, and I express my apologies for being late for this program because of a prior commitment. And my profound apologies to Dr. Rajiv Gupta, who has been waiting for that long. We have actually an interesting webinar today, and that is risk stratification in hypertension, or so-called high-risk hypertension. And to speak on the subject of high risk hypertension, we have none other than Dr. Rajiv Gupta. And if you have been interested in medicine and cardiology and you have not known Dr. Rajiv Gupta, then you have wasted your life. He is a fantastic, foremost cardiovascular epidemiologist of this country, Southeast Asia, and probably one of the best in the world. And it has been my pleasure of having known him for the last 30 years. He's the chair of preventive cardiology and internal medicine, Eternal Heart Care Center, Mount Sinai, New York affiliate, Jaipur. He's the chair of academic research development unit, Rajasthan University of Health Sciences, co-chair hypertension research group, task force member, ICMR, and he has more than 1,000 publications, 650 original articles, 100 book chapters, and 98,000 citations. He has been he has multiple articles in Lancet, New England Journal of Medicine, Nature, BMJ, JACC, etc. And of course, there hasn't been any international meeting on which he hasn't been a guest lecturer. And with those words, I would invite my dear friend Dr. Rajiv Gupta to talk about hypertension risk stratification and what is a high risk hypertension.
Sir, you're muted.
Thank you, Jagdish, for your kind words and your your introduction, a very wide introduction. So let's go straight to the topic, which is uh, risk stratification in hypertension. And as we all been working on this field for the last so many years, we realize now that hypertension was underdiagnosed in the past. And now, of course, it is the most important risk factor for global burden of disease. This is the GBD data published only last 6 months ago, and clearly showing that high systolic blood pressure kills more people other than any other country in the world, more than tobacco, more than dietary factors, more than pollution. We always talk of lack of data from India, but we have been doing this study known as the Pure Prospective Urban Rural Epidemiological Study. And in this study also, we found that hypertension was the most important cause, population attributable fraction. That means if you have 100 patients of heart disease, almost 14% will have hypertension as the most important risk factor. It is slightly lower in India as compared to other parts of the world because we know that in China, hypertension causes more stroke than heart disease, while in India, hypertension causes more heart disease than strokes. And we have high cholesterol, pollution, diet, diabetes. All these are important risk factors in our country. Now, what does hypertension do? And we all know that hypertension causes multiple diseases, mainly vascular, cardiovascular disease, ischemic heart disease, cerebrovascular disease, like hemorrhagic stroke, aortic disease, which is not very commonly diagnosed, but it is now increasing in number. We have more patients of aortic aneurysms, and as people are aging, even aortic dissections are coming up in our practice. At least in our hospital, we see about one case of dissection every 2 months, or and at times every one case a month. Come in very moribund condition. Many of them can be saved, many of them cannot be saved. So again, dissection is an important problem. Chronic renal disease and ocular disease also are part of that. We all know that hypertension has multiple risk factors, and it is a combination of genes, of biology, of social sciences, physical activity, and things which influence the individuals and populations. This is a very complex sort of a scenario, and to simplify that, there's a article on hypertension prediction scores. Now, can we predict hypertension? Can we predict the risk of hypertension in general population? Because there are multiple factors, as we know, there are prenatal factors, there are social factors, diet, lifestyle factors, salt intake, protein, physical inactivity, smoking, alcohol. And then there are clinical factors for hypertension like age, sex, body mass index, and diabetes. And then there are parental history, genetic variants. Studies have classified hypertension risk score. What are the hypertension risk prediction scores? And they use age, sex. These are the data from Framingham, not the Framingham cardiovascular risk score, but the Framingham hypertension risk score. Whitehall 2 also has developed a hypertension risk score, and we have from Eric and the cardiovascular health study both in US. They have combined equations using age, sex, systolic blood pressure, diastolic blood pressure, smoking, family history, no physical activity, body mass index, and diabetes. And you combine them, all of these together in an equation, you can predict that people who are the higher risk, more than third percentile of the risk score, tend to develop hypertension at a later age. So we can predict hypertension as in a young person also. And now, of course, we have gene risk scores. We all know hypertension is a polygenic disorder, although monogenic forms are well known. And they are based on the SNPs, they are single nucleotide polymorphisms. There are single nucleotide polymorphisms that influence systolic blood pressure, those influence diastolic blood pressure, and they also influence pulse pressure. So if we combine all of them in a single numeric, you can create sort of a umbrella type of thing, a U-shaped dumbbell, and people who are on the higher risk, that is the right side of the tail, they are the ones who are going to develop hypertension. So this is a genetic gene risk score. Right now, we are not talking too much about it because the technology is still primitive, still evolving. But I'm sure that in the next 5 or 10 years, we'll be talking more of gene risk score, not only in prediction of hypertension, but also in prediction of complications of hypertension. And that's why I think we need to understand that the risk stratification is important. We have a variety of medications for hypertension. We have a variety of other things for hypertension. How can we stratify risk of hypertension in a clinic, in a clinic in day-to-day practice? There are multiple variables which can be used for risk stratification. There have been studies on all of them. And I was just going through the European Society of Cardiology guidelines, and they have listed more than 100 factors, 100 variables for risk stratification. I just picked out some of them, which are possibly important in our context also. Diet, especially high salt intake, high fat intake, high calorie, and we should add even high carbohydrate intake. And there are some deficiencies of macronutrients. Smokeless tobacco is an important problem in our country. Physical inactivity, alcohol, pollution, psychosocial and socioeconomic factors. But I think we are also interested in the biological factors like age, like overweight, abdominal obesity, chronic kidney disease, and we already talked about the genetic risk factors. Now, can we combine them in a single metric so then we can identify a risk? Now, these are the European Society of Cardiology guidelines. They have classified on two things. One is the level of blood pressure. That means as the level of blood pressure increases from normal to high normal to grade 1 hypertension, grade 2 hypertension, there is an increase in the risk of hypertension. Not only that, if you have other risk factors, like you have no other risk factors, there is low risk, 1 or 2 cardiovascular risk factors, moderate risk, more than 3 risk factors, high risk. And then you have stage 2, which is asymptomatic disease, where you have evidence of hypertension-mediated organ damage or chronic kidney disease or diabetes without organ damage. Again, the risk goes up, and you have established cardiovascular disease, the risk is very high. The figure looks very complex. And what I have done is to use a very simple format. We all know that there are CV risk factor clustering and hypertension. Now, these are the old data from the Framingham study. And you see that only about 25%, only about a quarter of the people will have no risk factors. And the rest of them will have multiple risk factors. And these are data from our own study, the India Heart Watch, in 6,000 patients. What we did was stratification of people, men and women, with hypertension on multiple risk factors. We studied these 5 risk factors: smoking, cholesterol, triglycerides, metabolic syndrome, and diabetes. In normal intensive people, only about less than 50% of patients have one or more risk factors. But if the person has hypertension, almost three-fourths, more than 75% of people have multiple risk factors. So clearly, hypertension is not only a single disease, it is a polyvascular disease. And that's very important when you try to treat these people. We have known for many years now, these are the very old data published recently, but the data from the Mr. Fitch study, from the prospective collaborative study done about 25, 30 years ago. And they have clearly shown that along with blood pressure, if you have multiple risk factors like high cholesterol, HDL, diabetes, or smoking, the risk keeps on increasing. So that's the way of risk stratification, and that's what we have used. Now, we classify people into low risk if there is one major cardiovascular risk factor, intermediate risk if there are two or three risk factors, and more than three risk factors or evidence of target organ damage, they are high risk people. Now, this is a very simple algorithm. It can be remembered by every clinician. We can easily practice in a clinic. And I think it is very useful as far as the therapy is concerned, because I'll just show you what is the evidence as far as the therapy is concerned. And of course, we have gene risk score. We talked about it, that if you have a high gene risk score, you don't only have hypertension, but you also have incidence of complications of hypertension, but that is still some time away. So can we intervene according to risk? How do we intervene according to the risk stratification in patients with hypertension? Low risk hypertension, we all know what is the definition. Office blood pressure 140/90, ambulatory blood pressure 130/80, and the home blood pressure of 135/85. We all know the control targets. Initial target 140/90, high risk categories 130/80. And I think these are accepted now universally, although the American Heart and American College of Cardiology were the first ones to give the new targets of 130/80. But I think now all of us realize that this is the real targets which we all should strive to achieve. Therapy in these people, initiation with two drugs in most people, and combination of ACE/ARBs plus CCBs or diuretics as a initial combination. And European Society recommends a single pill combination therapy. Fortunately, in India, we have been using it for a long time. So this is the stepwise algorithm given by the European Society of Cardiology. One pill, initial therapy, ACE inhibitor or ARB, initial, and then a combination of the CCBs or a diuretic. Step two is again a pill, then you have three drugs. Step three is a triple combination or more, which is commonly known as resistant hypertension, and you can add spironolactone. But we also have Indian guidelines actually, and these are the Resolve program, which is sponsored by the Ministry of Health and is being implemented in multiple states of the country. I know Kerala, Andhra Pradesh, Madhya Pradesh, Himachal, Punjab. They have already implemented this particular algorithm for hypertension management. So all these are low risk people with hypertension. You need to screen everyone. First, initial therapy is amlodipine. Blood pressure not controlled, add telmisartan. If still not controlled, add chlorothalidone. That's what the guidelines say, and they're very clear on that. And if not controlled, then you refer it to a specialist. So this is at the level of primary care. And I think this is very important algorithm if you want to treat hypertension across the country so that we can prevent complications. We already talked of single pill combination. I won't go into details of that. We come to intermediate risk. And I think this is the most crucial identification of intermediate risk. In our studies, the TIPS study and the HOPE study, which we have been involved in, we have clearly shown that the inter-heart risk score, which is a simple risk score available in the computers, available on your cell phone, you can have the equation and you can add all these factors, and it gives you a risk of low, intermediate, or high risk hypertensive people. So multiple things are there. But I think you can even use the Framingham risk score to classify people into intermediate risk. If you have a person with intermediate risk, what to do? You stick to the stepwise drug therapy as we do for the low risk, but you add something beyond that. And that's what I think I'm deeply interested in, because we all know that hypertension is a polyvascular disease. This escort lipid lowering arm clearly showed almost 20 years ago that if you add a statin in uncomplicated hypertension patient, there's a 36% risk reduction. Unfortunately, guidelines have still are only now starting to focus on hypertension management using multiple therapies, and a combination of hypertensive antihypertensive medication with statin, I think, is a very important new development which has come for intermediate risk patient and the high risk patient with hypertension, even without vascular disease, even with normal cholesterol level. Same thing was shown in the HOPE-3 trial. Now, HOPE-3 again used the entire risk score to classify, and these were all intermediate risk patients. And the green line, which is the combined therapy of statins and of rosuvastatin and blood pressure lowering like candesartan and hydrochlorothiazide, had the best outcomes. Again, clearly emphasizing that we need to move beyond blood pressure control in patients with hypertension. We need to give them polytherapy, and at least I believe that statin is a very important addition to our armamentarium in treating intermediate risk people. And now we have polypill trial, the TIPS-3, again done largely in India, but also across the globe, with or without aspirin. And it again showed the polypill combination of atenolol, ramipril, hydrochlorothiazide, simvastatin. This was polypill A, and polypill B was we add aspirin into it. So if you have only these four components, there was a significant 21% risk reduction for major cardiovascular events at the end of 5 years. With this particular polypill, it does not contain aspirin. But if you see the other side of the slide, if you add aspirin to the whole thing, the risk reduction is even greater. So clearly showing that if you give polypill to people without cardiovascular disease, so they're all primary prevention patients. That means if you give them blood pressure lowering, if you give them simvastatin, and if you give them aspirin combination, it is useful. And what polypill also showed that it was more useful in patients with hypertension. So this again shows that if hypertension, the risk reduction was to the tune of 32%. So clearly, I mean, identifying that we need to move beyond single or blood pressure lowering into the realm of polyvascular interventions in intermediate risk and high risk patients with hypertension. What is the reality? These are data from our own Jab Heart Watch registry on hypertension, just coming up in publication in the JAPI this month or next month. 3,000 patients, and what we see that the use of statins. This is the data from 2 or 3 hospitals in Jaipur, and is about 55% in high risk people, 47% in intermediate risk, and 28% in low risk. These are people without vascular disease. So clearly, we are doing something to these people, but we are not doing them good enough. And finally, we have high-risk hypertension. High-risk hypertension, what we know is we can either do by inter-heart risk score, or if there is evidence of target organ damage, we can do through that also, cardiovascular disease, congestive heart failure, aortic disease, peripheral arterial disease, proteinuria, chronic renal disease, or retinal vascular disease. Any of these diseases, we all know compelling indications. If you have hypertension and coronary artery disease, you give after ACE, ARBs, beta blockers, CCBs. So this is the initial therapy, and then you can add combinations. If you have hypertension with chronic kidney disease, ACE, ARBs, and CCBs are drug of choice. If you have hypertension with reduced ejection fraction heart failure, again you have ACE inhibitors, beta blockers, and diuretics as the first choice drugs. And hypertension with atrial fibrillation, ACE inhibitors, beta blockers, or non-dihydropyridine CCBs like verapamil or diltiazem, they are the initial therapy. So you keep on changing your hypertension management strategy according to the risk of the person. Ultimately, I think in the next 4 or 5 years, what we will have clinical risk, as we have just discussed, low risk hypertension, intermediate risk, and high risk. There will also be availability of the polygenic risk scores, especially the hypertension polygenic risk scores. And ultimately, I think in the next 4 or 5 years, we'll be treating patients based not only on the clinical risk score, but also on the genetic risk score, which will be more beneficial to the patient. So in conclusions, we all know that hypertension risk prediction scores can be useful for identifying high-risk individuals to develop hypertension. We can do that by Framingham hypertension risk score or the Whitehall risk score. But risk prediction in clinical hypertension is a useful strategy for identifying or intensity of treatment and drug choices. And we already have said that European, American, WHO, and Interheart are common risk prediction tools. What I believe is that the simple tools are more useful and practical, low risk, intermediate, and high risk, depending on the associated cardiovascular risk factors. But I think it's now time to highlight the importance of therapies that target multiple risks so that we can reduce the cardiovascular risk in these people. We have to have focus on standard treatment to reduce blood pressure. We need to maybe add statins or polypills in intermediate and high-risk people. And we need to focus on additional therapies for target organ damage and compelling indications. So thank you very much for your time, and thank you very much. I'll be glad to answer any questions if they are there. Thank you.
Thank you, Dr. Rajiv Gupta. As usual, it was full of facts and full of important information, data, largely your own work and work of your colleagues with whom you have been associated with for a long time. And it clearly tells us that the hypertension needs to be risk stratified and treated accordingly, not only with antihypertensive drugs, but other vascular protective agents as well. And I think we would have this discussion in greater detail along with our panelists after a case presentation by Professor Tom Devasia, who is the professor and head of cardiology, Kasturba Gandhi Medical College and Hospital, Manipal. And he is going to present a case, low risk versus high risk hypertension management strategy. Essentially, it is an overlap, what you have discussed and what case he is going to present. And then after that, we'll involve Dr. Rath and Dr. Shah in this panel discussion and get their views as well. So without taking any more time, Professor Tom Devasia.
Thank you very much, sir, and good evening and warm regards to everybody from Department of Cardiology, Kasturba Hospital, Manipal. Is my slide visible?
Yes, it is visible.
So I will be discussing a few cases to incite some discussion so that these are cases which we come across in our everyday life, and then that I hope that the panel and the other presiding person and the moderators and other speaker can contribute. So I'll just go through my slides. The first case is a discussion thought about office versus out of office BP measurement in the diagnosis of hypertension, what to do. So this is a sample case where a 57-year-old bank manager presents for a BP checkup. He did his annual checkup, and 2 months ago, that time his BP was found to be high. But he claims that whenever he checks BP at his nearby clinics, it is all normal. His hematology is normal. His biochemistry, creatinine, electrolytes, all are normal. His ECG is normal. There is no evidence of left ventricular hypertrophy. And his office BP using auscultatory mercury sphygmomanometer was 152/102. Now, how to proceed? So as we already know, we do not recommend mercury sphygmometer sphygmomanometer anymore, and the auscultatory method is also not the choice of for blood pressure measurement. Now, as we all know, the most preferred mean to diagnose hypertension is the out of office assessment, and we have to measure blood pressure using an electronic oscillometric upper arm device which is automated and not using the stethoscope auscultatory method. So if they come to us for an office visit in our outpatient, if we measure a blood pressure and if the blood pressure turns out to be more than 180, 110, then yes, the patient is hypertensive. And if the patient has diabetes, then we check ideally automated office blood pressure. And if it is more than 130, yes, the patient needs some management. If the patient is not diabetic and if the automated office blood pressure is more than 135, then also, yes, the patient needs some medication. And the patient's most preferred out of office measurement would be an ambulatory blood pressure monitoring, and a daytime mean of more than 135/85 will warrant diagnosis of hypertension. And if we are calculating it over a 24-hour mean, more than 130/80 will warrant diagnosis of hypertension. And if the patient do not have a high blood pressure by an ambulatory blood pressure monitor or an automated office blood pressure monitoring, then we will have to presume that this patient's blood pressure, which we measured, is actually white coat hypertension. Some of the basics of blood pressure measurement for the sake of the audience, especially postgraduate students. If automated office BP is used, use the mean calculated and displayed by the device. If non-automated office BP is used, take at least 3 readings, discard the first and calculate the mean of the remaining measurements. And of course, we have to perform a history and physical examination. And the automated office BP measurement is performed with the patient unattended in a private area, not in the clinic with the doctor. And a non-automated measurement is performed using an electronic upper arm device with the provider in the room. The diagnostic thresholds for automated, ambulatory, and home BP measurements in diabetes patients are yet not fully established. And as of now, it is 130/80. Serial office measurements over 3 to 5 visits can be used if ambulatory blood pressure monitoring or home measurement is not available. And home BP series, if somebody is taking at home, you have to ask them to take 2 readings each morning and evening for 7 days. That will make about 28 readings total, and discard the first day readings and average the last 6 days. Annual BP measurement is also recommended to detect progression to hypertension. As I have already showed, out-of-office assessment is a preferred means to diagnose hypertension. Out-of-office measurement is important because it helps to identify white coat hypertension and masked hypertension. Ambulatory BP monitoring is recommended because it has better predictive ability than office BP monitoring. A home BP monitoring is not as good as ambulatory BP monitoring, but it is still better than office BP monitoring. Out-of-office BP monitoring are so important because they correlate well with systolic blood pressure and diastolic blood pressure, leading on to future risk, both in terms of left ventricular hypertrophy and albumin excretion ratio. As we know, if we compare the manual office BP monitoring and ambulatory BP monitoring, we can diagnose white coat hypertension if the office BP is high, but the ambulatory BP is low. True hypertension if both office BP and ambulatory BP is high. Masked hypertension if the office BP is low, but the ambulatory BP is high. And of course, if both are normal, then we don't worry about the patient. This is the relative risk of developing cardiovascular events. From this chart, it is quite obvious that masked hypertension patients are at highest risk, and then comes the uncontrolled hypertension groups, and white coat hypertension may be marginally having more risk than people with normal blood pressures. It is very important that we recommend automated office BP measurement with these kind of oscillometric or electronic devices, and not other devices, and it has to be an unattended BP monitoring or measurement. The automated office BP measurement closely approximates an ambulatory BP measurement, and it is very much predictive or more predictive of end organ damage like LV mass index, proteinuria, and carotid intimal medial thickness, similar to ambulatory BP monitoring. Now, something we should ask ourselves as clinician is, what device do we use in the office to measure blood pressure? Is it an automated, or we are still using the old devices? And what is our opinion about home BP assessment to the patients? Do we allow our patients, do we advise our patients to measure blood pressure at home regularly and keep updating or show us the chart when they visit us? Of course, we know that the people who are at high risk, the threshold and the target blood pressures are lower. And the diagnosis of hypertension, we focus nowadays exclusively on preferably out of office measurement, and in the office we use automatic BP monitoring. Now, moving to yet another case, I would like to discuss this case as well with Mr. X, who is 76 years old, who has had a recent MI 2 years ago. He comes to the outpatient department for hypertension. There is no angina now. He has been hypertensive for the last 20 years with blood pressure of 135/80 at home. He is on treatment with amlodipine, olmesartan, hydrochlorothiazide, and bisoprolol. He has a normal cardiovascular system examination, and his office blood pressure is 135/80. He has normal hematology. His LDL cholesterol is at target. His creatinine electrolytes are normal. His ECG shows evolved anterior MI, but no LVH and normal LV function on echo. What should be his target blood pressure? Let us look at some of the things. Now, these are the threshold values for initiation of treatment for various category of people as per the sprint population. If you look at the high risk group of patients, which my previous speaker has already described, the systolic blood pressure, anything more than 130, we are supposed to optimize medicines or initiate pharmacological treatment. Diabetes, more than 130/80, you need to step up medicines. Those who are at moderate risk, more than 140/90, you need to initiate medicines. Those who are low risk, maybe you can wait unless the blood pressure is more than 160/100. Now, what target do we treat their blood pressure? Of course, the treatment consists of lifestyle changes and pharmacological management. The high-risk group, we should aim to bring down their systolic blood pressure to less than 120. Diabetes people, we should aim to bring down the systolic blood pressure to less than 130/80, and all the others, maybe we can keep it below 140/90. After the sprint trial, the new guidelines for hypertension suggest that for high-risk patients who are more than 50 years with systolic blood pressure of more than 130, we need to be more intense with the management with medicines to target a systolic blood pressure of less than 120. And these intensive management should be guided by an automated office BP measurements. And patient selection is very important, especially the high-risk group and the elderly, because we do not want them to develop symptomatic hypotension or renal hypoperfusion, leading to complications. Now, the new targets for high-risk patient after the sprint trial, who does this apply to? People with cardiovascular disease, people with chronic kidney disease, people with an estimated 10-year global risk of more than 15%, and age more than 75 years. However, we have to keep in mind that there was an increased risk of renal deterioration, potassium abnormalities, and hypotension with the intensified therapy. So patient selection and close monitoring is very important. Now, for these whom this not apply to, patients with heart failure with ejection fraction less than 35%, people with recent MI, people with previous stroke, and patients whose standing blood pressure is less than 110. All these people, these rules do not apply. So something we should think about with respect to this case, when we treat a patient, do we document the BP target on the patient's chart? What is it that we are aiming for? Do we tell the patient what is the target that the patient should focus on as far as BP is concerned? Well, we know that the long-acting diuretics are preferred compared to short-acting diuretics. And as far as possible, single pill combination should be used as a first line management. So let us move to yet another scenario where a diuretic is being used for hypertension, and how do we choose the diuretic and when do we choose the diuretic. This is an example of a case. Krishna, 53 years. He is a smoker. He owns a hotel. He has been diagnosed as hypertensive in his yearly checkup 2 years ago. Then he became very much health conscious. He lost 15 kg. He works out. He walks every day. He tries to keep his fitness, but he is unable to stop smoking. His lipids are normal. His HbA1c is normal. He has no signs or symptoms of a target organ damage. His initial prescription was hydrochlorothiazide, but with home BP readings averaging 154/90 in the morning before medicines and 132/84 in the evening. Now, what should we do? Do we leave things as they are and allow him to continue hydrochlorothiazide, or should we add another drug? We know that we prefer the longer-acting diuretics, which are thiazide-like diuretics like chlorthalidone, indapamide, or metolazone. The shorter-acting ones, which are hydrochlorothiazide, is not preferred. Now, this is a diuretic type meta-analysis versus placebo. We know that both types of diuretics will reduce cardiovascular events and cerebrovascular events and heart failure. But only thiazide-like diuretics and not thiazides additionally reduce coronary events and all-cause mortality, as the chart shows. Chlorthalidone is more effective than hydrochlorothiazide in BP reduction. This is evident from this chart at 12 weeks of. In summary, longer-acting diuretics are preferred because they are more effective at reducing cardiovascular events and systolic blood pressure and diastolic blood pressure than short-acting diuretics. So, looking back, in patients who are currently taking a short-acting diuretics and have good blood pressure control, do we change them to a long-acting diuretic? Something we need to think for ourselves. And what do you think constitutes a good blood pressure control? It is just blood pressure control, or is it also using drugs that can reduce cardiovascular and cerebrovascular events? A single pill combination should be used as a first line treatment, regardless of the extent of BP elevation. How true is it? Let us look at another case, managing a patient with multiple risk factors. Rajan is 59 years old. He has remote history of pre-diabetes, mild hypertension, and dyslipidemia. We have not seen him for the last 3 years, and he says, I just got tired of taking all the pills and I stopped it myself. But later on, his older sibling develops an MI, so he gets motivated by his family again. He comes to reassessment of his cardiovascular risks. His blood pressure is 146/92. His HbA1c is 6.8. His LDL is 150. In what antihypertensive therapy would we consider for him? In 2016, we were following this. In addition to health behavior management, we could consider thiazide, ACE or ARB or long-acting calcium channel blockers. And if the blood pressure was more than 20 systolic or 10 diastolic above the target, we used a combination of 2 first-line drugs. But now, since 2017, we follow this. We have all this, plus we have an option of a single pill combination. We also consider longer-acting thiazide-like diuretics over shorter-acting thiazide diuretics. Beta blockers are not indicated as first-line therapy for 60 years and above. Let us have a look at the single pill combination option where there is an ACE inhibitor and it is combined with a calcium channel blocker, or an ARB may be combined with a calcium channel blocker, or an ACE inhibitor or ARB may be combined with a diuretic. So what is the advantage? They have better adherence, they have probably better BP control, and initial combination therapy, there is reduced risk of cardiovascular events than monotherapy. There has been 2 key studies establishing the utility of single pill combination, the HOPE-3 and ACCOMPLISH, which my previous speaker has already described. The single pill combination combining an ACE inhibitor or ARB with calcium channel blocker or diuretic as first-line therapy would be the best option. So looking back at this case, let us think for ourselves, will we start patients with newly diagnosed mild hypertension on a single pill combination therapy? What are our barriers to prescribe a single pill combination? The longer acting diuretics are preferred, as we have already discussed, and the single pill combination is the first line treatment as much as possible, regardless of the extent of BP elevation. Thank you very much. I hope these 4 cases will help to incite a lot of discussion among the attendees and of course the panelists. I hope that you take this discussion forward.
Thank you, Professor Tom. Those 4 cases, I think you showed the diversity of hypertension in general population, and also, of course, the treatment strategies may differ. Although the views you have presented may be very different from what many people think, we also know there are subtle differences between ESC guidelines and ACC/HA guidelines. We are also aware of the fact that in May 2020, International Society for Hypertension came out with different guidelines, somewhat different guidelines than the ESC and of course the ACC/HA. We also know that the Indian guidelines are somewhat different, and to some extent, the Government of India initiative talks totally different, as Dr. Rajiv Gupta talked about. So we'll discuss all these issues, and I welcome our both panelists, Professor P.K. Rath, who is Professor of Cardiology and former Head of Department of Cardiology, Medical College, Behrampur. He's a Fellow of Cardiological Society of India, Fellow of Indian College of Cardiology, and Fellow of European Society of Cardiology. Welcome, Dr. Rath. You will be joined with Jay Shah.
Thank you, Dr. Mohan.
You will be joined by Dr. Jay Shah, who is Head of Department of Cardiology and DNB teacher from Ahmedabad, founder member of the Krish Heart Foundation and Director, Krish Heart Clinic, and he has more than 50 national and international publications, and he has been an investigator, co-investigator of landmark trials like CANTOS, Melange, Credence BRS, Cadence BTK, and he has been invited as a faculty to various international conferences. So welcome, Dr. Jay Shah, and I'm so happy that you could join us on this Saturday evening. And between Dr. Rath, Dr. Shah, and of course, Dr. Devasia and Dr. Rajiv Gupta, before we go further, let us try to answer questions put in the chat box. Okay. So we'll quickly take the questions which have been put in the chat box, and I will direct these questions to different people. So please don't mind if you don't like my sequence. So the first question is to, of course, Dr. Rajiv Gupta. What would be the impact of dealing with these risk factors before development of hypertension? How much beneficial is it? So the question is clear. Suppose somebody has only dyslipidemia or diabetes and still is normotensive. Controlling these, would this prevent development of hypertension? Dr. Rajiv Gupta.
Thank you for that, difficult question. Can we prevent hypertension? There is a very major issue to be discussed. Lifestyle interventions are useful, but lifestyle interventions have to be strictly followed. Diet, for example, weight management, for example, exercise, for example, and I think these three, and tobacco, alcohol also. So I think all these 5 interventions, if you do them strictly over a period of your lifetime, you can prevent development of hypertension. But can we do it? There's $1 million question. And most of the trials have shown that the lifestyle interventions work to a certain extent, to a certain time, maybe 2 years or 3 years. And then after that, people go back to developing hypertension. That's number one. If you have associated risk factors, what is the role of, lifestyle interventions versus pharmacotherapy? Again, a difficult question. Although the TIF3 trial, which had almost 25% of people with normal blood pressure, and they were given these antihypertensive medications, and there was a risk reduction, although not to the same extent as in hypertension, is provocative in that direction, in that issue. And I think Dr. Mohan can comment more on that. But I think lifestyle interventions are important. Thank you.
Yes, I would agree. Actually, this issue whether treating an independent risk factor will decrease the chances of developing hypertension, nobody has looked at this issue. Suppose I have a LDL cholesterol 150, I bring it down, and over 5 years, what are my chances of developing hypertension? I don't think we have answer to that. Yeah. Similarly, we have no answer to adequate control of diabetes in an apparently normotensive individual. There could be, of course, incidentally, the obesity definitely. I mean, you control obesity, as you rightly said. If obesity is considered a risk factor, definitely reducing weight will reduce the chances of developing hypertension. That is a consensus. I mean, we don't have any randomized data, but I think that's the consensus that it will prevent development of hypertension. We would come to our panelists with this question again, but let us quickly go through the other questions. And again, Dr. Rajiv Gupta, I will take this question first to you and then to Tom. Should all elderly be considered high-risk population?
I will think yes, because I think age is a very important risk factor for cardiovascular events. So I will consider people beyond a certain age. Now, what is that age? I don't know actually, because initial polypill trial said everybody over 60. Then he said everybody over 50. Framingham risk score says 60 is the cutoff. So I think we have variable cutoffs. In India, we have 10 years premature heart disease. So maybe 55 is a good point in our population. And I think beyond 55, I will consider everybody as a high risk and focus on vascular management.
That is good. Actually, you skillfully and diplomatically decline to define elderly, because probably you know my age as well as your age. Good. Tom, what do you think about this? Should all elderly be considered high-risk population?
I think so, sir. I think so.
Good. What about Dr. Jay Shah?
Yes, sir. I think as Dr. Rajiv sir has already told that we as an Indian, we are anyway, we are being affected by nature and nurture both. So that is something which keeps all of us at a high risk, especially when we are talking about elderly population. Then yes, I think we are at the increased risk of development of hypertension. And when premature coronary artery disease is concerned, we are anyway 1 decade earlier than the Western populations. So I think my answer is also in agreement with Dr. Rajiv sir and Dr. Tom.
Dr. Rath, any disagreement?
No, I also fully agree that the elderly age group itself is a risk because it has got certain biological changes. Your arterial wall becomes thick and elasticity is lost. So you record a pseudo hypertension. We have got no idea really in the elderly people what the indirect method of recording the blood pressure is. It the same when you do a intra-arterial recording. But for practical purposes, we have to go for an indirect method of recording what is being prescribed. So they carry a risk of developing an hypertension. Similarly, there is in addition to the vascular remodeling, there is a left ventricular remodeling takes place here. The diastolic function becomes altered as the age advances. So by itself, the age is definitely a risk factor for all this. So we have to keep in mind as we advance with the age, definitely we carry a risk. So we have to look for all other comorbid conditions and we look for the lifestyle changes strictly to be followed. This is my view.
Good. We come to question number 3 from the chat box. And the question is, in the concept of polypill, how is the combination of older molecules, simvastatin and ramipril, justified in light of availability of new molecules? I think the objection is probably to simvastatin. What do you say, Dr. Rajiv Gupta? Should you have objection to that?
I will. We discussed that in when the polypill trial was being initiated. Atorvastatin at that point of time was patented molecule across the globe in most of the countries. So that's why simvastatin was chosen. If I were to design a new polypill, possibly I will be focusing on rosuvastatin. With India, at least, it is off patent. I'll be focusing on the ARB instead of ACE inhibitors. And even the beta blockers will be different as compared to atenolol. So I think this is a dynamic sort of a situation that we keep on changing the mixture of the molecules as the knowledge evolves.
Yes, I would completely agree with you. After all, it is the choice of drugs is a time-dependent phenomenon. In which era, which circa, which period you designed a study and you conducted a study. There is no doubt, and you would recall that when I was doing DM, the dose of aspirin was 325 milligram to everybody. You just have come down by to 1/5 of that, 1/4 of that. Things do change over a period of time. So let's come to another question. This I will start with.
Dr. Mohan, can I interrupt here?
Yeah, please, Doctor.
You see, the polypill, what has been recommended, I have got a disagreement to this point. The polypill should not be confused with a multiple therapy or multiple agents for a treatment of an hypertension. The main drawback of polypill, first I'll say main advantage of polypill is the patient acceptance. Patient will be happy taking one tablet. But the main drawback of a polypill is that we are not able to titrate the target doses for each agent. And suppose you are using this and the target BP is not reached, then what next? Then you have to break it and go for different combinations. So polypill doesn't mean that you have got no sort of rationality to add different agents with a different strength to reach the target dosage. So in my opinion, polypill, instead of polypill, go for 2 or 3 different agents with a different mechanism of action to target the blood pressure.
No, the whole concept behind this, as Dr. Rajiv Gupta would tell you, is population control, the control of the risk, overall cardiovascular risk in the population. In a given case, this is not the strategy. It's not an individual-based strategy. It is, we know from pure study that cardioprotective drugs for secondary prophylaxis in India are being taken by 10% or less people. Polypill will definitely improve the compliance, and at least for secondary prevention people, and would improve, as he has shown in the TIPS 3 study with aspirin, a 31% reduction. I think it's a population related strategy and not individual related strategy. What do you say, Dr. Rajiv Gupta?
Yeah, I think I agree. It's basically a concept that we need to have a polypharmacy Now, polypharmacy could be a single tablet, could be 2 tablets or 3 tablets. So I think this is a pharmacologist and the clinicians to decide what do they want to give to a particular patient. So I think we have a multiple sort of type of drugs, and then we want to have a single molecule in that particular cocktail, or we want to have multiple molecules in that particular cocktail, is an individual choice. So I think that will go with the physicians.
Yes. And also we should not forget that for population-based strategies also, people have difference of opinion. In fact, one school of thoughts thinks that a 20 milligram rosuvastatin is the perfect polypill. It is a single drug, but is a perfect polypill. It will cut down the risk by at least 35 to 45%, depending on what you are seeing. If you are seeing the Jupiter study, then of course you have a 45% reduction. And if you are looking at HOPE-3, then it's 35, total of 25% overall reduction, and MI, of course, 35%. So those are different views. I think we are digressing from our main topic. Let's come back. But then the questions actually are general. Again, the general question: what would be the recommended glycemic target in elderly Indian diabetic patient for their risk stratification? Dr. Rath, we'll start with you. Elderly person glycemic target for an Indian diabetic.
You see, when we treat a patient for a diabetes and strict, because many trials have shown that a strict control of the blood sugar is not that advised. There are complications are there. So I think the endocrinologist will better answer what is the target, but a strict rigid control of a glycemic status has been shown not to be so beneficial. This is my opinion.
Yeah, I would agree with that. Actually, the best study, the longest study, Steno 2, clearly tells you it has to be a multi-pronged strategy with greatest emphasis on lipids, essentially LDL, followed by on blood pressure. And of course, cessation of smoking is important, lifestyle is important. And of course, the glycemic control actually accounts for the least amount of benefit amongst diabetics. So that is a very interesting thing. I mean, it flies in the face of a UKPDS study, but then we are not discussing diabetes today, so we'll try to actually avoid that. The next question is, and this is a question on which I think we all would agree, the experts will completely agree. Is antiplatelet therapy a more reasonable alternative than anticoagulation in elderly with atrial fibrillation? Dr. Tom?
Well, many data has already shown that the choice of therapy for patients with atrial fibrillation is anticoagulation. Maybe antiplatelet like aspirin gives some benefit, but if you would like to extend the largest possible benefit to a patient with hypertension, with atrial fibrillation, then it is better that we follow the CHADS-VAS scoring system, assess the risk properly. Maybe we can access the HAS-PLED scoring system as well to know the risk for bleeding and then proceed with anticoagulation.
Yeah, but I think we have clear-cut on first thing guidelines. Guidelines have given aspirin or antiplatelet therapy class 3B indication.
Yeah.
Those latest guidelines again, that aspirin is positively harmful in patients who have high cardiovascular atrial fibrillation. There's no doubt about it. It is positively harmful. It doesn't prevent against stroke, but it increases the risk of bleeding. We also have data from Avro study, Action W study, Active W study. We are clear that bleeding risk is same with aspirin and oral anticoagulants, but the benefit is at least 3 times higher with anticoagulants compared to aspirin. So I think we are clear about that. Let's go to the next question. Now this is also a general question, and we would actually start with Dr. Jaisha. What
Yes.
was the role of echocardiography in the low-risk hypertensive population?
I think very important question, because as a general population, echocardiography is now considered as one of the important screening tool for all those who are having hypertension. And by detecting the presence of left ventricular hypertrophy, you can assess the patient, because then it is known as hypertension mediated target organ damage. And that is how you can always stratify the risk. As Dr. Rajiv sir has already stratified certain risk factors, whether they are intermediate risk factor or a high risk, where LVH or a left ventricular hypertrophy, which can be easily picked up on ECG as well as echocardiography, that can be taken as a part of a target organ damage, and that can be further stratified with the help of another inclusion in form of urinary albumin or urinary albumin creatinine ratio, or presence of retinopathy on and fundus examination, and calculating EGFR. So all these things, all these factors are basically conglomerating with each other, and that is how we always stratify the risk for all hypertensive individual and then treat them accordingly.
Yeah, I would agree. See, if we can find a way in which we can combine four things: quick, cheap, inexpensive, a screening echo, looking for albuminuria, a screening echo, a natriuretic peptide, and maybe actually an ECG actually, for multiple reasons. A very inexpensive way of doing these things, quick method, I think it will risk stratify a large number of our hypertensive patients appropriately. Our difficulty is when we do echocardiography, most people don't measure the left ventricular mass, number one. Even if they measure it, they won't index it. The machines give it automatically. People don't even write that report. And of course, the other things are diastolic function, the global LV strain and global LA strain. Each of these nowadays automatic equipment gives you 30 seconds. 30 seconds each actually for doing. I actually sometimes get surprised why a good echo is not possible in hypertension in 5 minutes. It's absolutely possible in 5 minutes, unless people are very obese and of course the window is very poor. I actually agree with you about albuminuria part. Fundus, sorry, the fourth part was fundus actually, not the ECG. The ECG will come later on actually. The fundus is very important. I do agree. I am a strong believer that echo can provide a lot of information if you are actually, you are a believer about diastolic function, about strain, and all those are nowadays possible with the equipment without applying your mind. More and more artificial intelligence is being put in echo machines, more and more every day. And even the cheapest possible. I'm surprised, actually. I would give an example. We have the latest T8. It is so cheap machine, and it tells you everything. I mean, it gives you LA strain, LV strain, every damn thing in a Ziffy, and doesn't cost anything. As a matter of fact, I'm actually surprised that it costs less than a treadmill equipment from GE.
So that is true.
Well, hello.
Yeah.
Dr. Mohan?
Yeah.
Hello?
Yes, please go ahead.
Can I suggest something?
Yeah, please go ahead.
See, my feeling is that whenever we see a patient, even at the first time, and then hypertension, whether it is whatever the stage it is essential to examine the patient as a whole, and the investigations or the various things what we should look at the beginning, and also to be subsequently annually or twice in a year to be followed up. It consists of an ophthalmoscopy, an echo assessment, serum potassium assessment, renal function assessment, albuminuria, either overt or microalbuminuria. These should be the routine, and they should be screened. And the screening are very essential because cost effective to know what are the SO and thyroid status also.
I would agree with you. I would completely agree with you.
Yeah, and they should be routinely screened by at least once in a year or two,
yeah, these are
even though the BP remains under control.
These are exactly what is mentioned in guidelines. What you are describing, both guidelines have mentioned all these tests, and they have mentioned periodicity may differ. Actually, in an uncomplicated hypertension, once in 2 years, maybe in a complicated hypertension, maybe once in a year or even earlier. Those are you are absolutely right. Actually, in our country, a lot of these standardized validated tests are available at a very affordable cost.
Yeah.
We shouldn't mind doing them.
Yeah.
Next question. Now again, we are digressing from hypertension, but that question of high risk brought actually a lot of other type of questions. Every diabetic patient should receive statin therapy irrespective of their risk. Do the same stand for true for all hypertensive individuals?
I think no data.
I think lipid tension is something which is a new terminology which has been given, and there is a complete correlation of having a dyslipidemia in a hypertensive individual, but yes, with a background of diabetes as well. So I think we must always go for a lipid profile test even in a uncomplicated hypertensive scenario.
I think Dr. Rajiv Gupta gave a very good answer to that. All intermediate risk and high risk have to have statin.
Yeah,
He showed good data of the HOPE-3, a 25% reduction in triple endpoint or 5 endpoints. I'm sorry, I get into this 3-point MACE. It's a 5-point MACE actually in a HOPE-3 study, and also the same kind of data was there in HPS-1. Actually, the heart protection study 1 also had about 1/3 patient who had treated hypertension as the criteria of treated hypertension, and looking at them, they were intermediate risk. So probably intermediate high risk, definitely. Low risk individuals, I think we would still need data about hypertension. Dr. Rajiv Gupta, your opinion?
I totally agree with you. I think statins, of course, are a useful drug. They are not very expensive. But we are adding one more pharmacological agent in persons with low risk, which is possibly a lifelong therapy. So I think low risk, we need more data. Intermediate risk and high risk hypertensives, even with the normal cholesterol levels, I will recommend using a statin.
We would come to actually, so the people are asking comments about management of sleep apnea and management of hypertension. Dr. Rath, let's start with you. Any comments on managing sleep apnea, investigating sleep apnea across the board in all hypertensive individuals, or at least resistant hypertensive individuals, and managing sleep apnea? What are your thoughts on that?
Yeah. You see, sleep apnea is one of the things which is not very well, people are giving importance to that, but it carries a lot of importance because incidence of sudden death is very high in the patient, those who have got episodes of sleep apnea. So here the patient's history rather than the patient's wife, the spouse history is very important really. And if there is any suspicion, they should be evaluated with a study to confirm the diagnosis of sleep apnea. And more so if the patient is obese or a diabetic, then the patient should be put on a CPAP machine to control the sleep apnea, because sleep apnea is definitely an important risk factor when there are associated risk factors like hypertension, obesity, and diabetes. So sleep apnea has to be given a due attention. This is my feeling.
Yes, but you know what we need to understand is that randomized trials on sleep apnea in resistant hypertension done from Spain, a big multi-center study has shown that control of sleep apnea reduces systolic blood pressure by 3 millimeter and diastolic by 2 millimeter. Sleep apnea is a good way of improving quality of life of these people, preventing accidents, probably reducing obesity. But if you are thinking it as a strategy for controlling hypertension, the data actually is not in favor of this strategy. I also know some people have shown as much as 20 milliliter decrease in blood pressure, but those are, I think, exceptional cases, and we need to keep that thing in mind. So, Dr. Jay Shadi, in the same actually question is another sub-question. Do SGLT2 inhibitors have any beneficial role in resistant hypertension?
Very interesting. Till now, I think SGLT2 inhibitor has got quite a bit of acceptance amongst the fraternity of medicine, especially cardiology and diabetology, as far as the heart failure is concerned. But as a part of hypertension for the treatment, I think we need some more data. And SGLT2 inhibitor till now, they have got included as a fantastic four, especially when we are looking for the Canadian Cardiovascular Society guideline that along with beta blocker, SGLT2 inhibitor can be started as a first-line therapy in a HFrEF patient, that is heart failure with reduced ejection fraction. But as far as hypertension per se is concerned, I think the role of SGLT2 inhibitor requires little more data. We have ample of data as far as heart failure and CKD is concerned. But as far as hypertension is concerned, I think maybe you can throw some more light, sir.
No, I think we have actually a good number of the studies have been published in circulation in last 2 years, resistant hypertension and SGLT2 inhibitors, but they're all diabetic individuals, not in non-diabetics.
Yeah.
And the data suggests that nocturnal hypertension is reduced more by SGLT2 inhibitors, possibly because they improve natriuresis, which actually anti-natriuresis thing is important for resistant hypertension. But having said that, the numbers are not in 2-digit. It's not a 2-digit reduction. It is still a single-digit reduction. Dr. Kenneth Ferdinand published a study saying up to 8 millimeter reduction in systolic blood pressure. Somebody said 6 millimeter. So probably they would be complementary. They wouldn't be the primary anti-hypertensive agents. Let's come to the next question. The next question is, what about role of statins in hypertensive patient with cognitive decline? Dr. Devasya. Somebody has cognitive decline and hypertension. Would you use statins?
You mean, are you asking whether are they asking whether the statin will reduce the cognitive function? Or are they asking whether statin will help in control of blood pressure?
So at the back of the mind of the people, there are studies, there are isolated case reports where people have suggested maybe statins cause cognitive decline. By reducing the cholesterol from the cell membrane of gray cells, these drugs might be causing cognitive decline. We are aware of the fact that people have done some analysis of all the trials published and haven't shown that cognitive decline is a big issue. But what are your thoughts on that?
Well, I do not give a lot of priority for a decline in cognitive function when I'm planning to write statin for a patient, because I know that the benefits that the statin would extend to the patient in terms of MACE and other complications are going to far exceed the probable small chance of a cognitive dysfunction, which may be contributed by other factors as well.
Yes, I would agree.
Can I answer that question?
Yeah, please go ahead.
I think HOPE-3 published a paper, I think some late last year, showing that there was no influence of cognitive use of statins, and this was fairly high dose rosuvastatin on cognitive functions at least the end of 7 years. So this is a pre-hoc. This was part of the HOPE-3 trial, showing the cognitive function decline did not happen with statins. The second TIPS-3 also is looking at cognitive functions. The follow-up is going on regarding cognitive functions, and we'll have some data on that coming out shortly, maybe in the next year or so. But I think statin cognitive function dysfunction equation, I think, is a controversial statement. And right now, at least after today, there are no trials clearly showing that statins lead to cognitive decline.
I would agree with you. Actually, that is the consensus. But there are others who say that maybe the cognitive function will improve if you prevent actually multi-infarct dementia.
That's right.
By decreasing ischemic strokes. We have data from CARD study and Jupiter study, both showing a 40% decrease in ischemic stroke incidence with statins. Both have a very similar kind of data, 48%. And if you reduce the multi-infarct dementia, I think there would be a decrease. Could be actually preservation of cognitive function if statins are used in high-risk individuals. Next question. How to treat isolated systolic hypertension, especially in elderly, say 70 years old with blood pressure of 180/70? Jay, Dr. Shah, Yours.
Actually, it's very simple. I think isolated systolic hypertension means you need to include calcium channel blocker by any means, and that will help in reducing that isolated systolic hypertension. But especially in elderly population in tropical country like ours, you need to be little more vigilant in prescribing diuretic. As we all know that diuretic and calcium channel blocker are the cornerstone of therapy in isolated systolic hypertension in elderly population. But you should be very careful in giving a high dose of diuretic, and you might choose maybe indapamide for that matter, which is a very good underutilized molecule as far as antihypertensive action is concerned. It has got more data, especially in a stroke prevention, also in elderly hypertension. And along with that, maybe calcium channel blocker along with ACE inhibitor in form of perindopril or telmisartan. All these things are being studied very extensively in different trials, and they have proven to be very beneficial, especially in elderly population.
So we have actually the data of Sprint elderly data, which is about 25% entire Sprint population. We have data from HIVET. We have data from CIST-EUR. And most of these, there was another data actually, hypertension in the elderly, European data. I'm forgetting the name of the study, but all have conclusively shown that lowering blood pressure benefits. Target still probably primary target is below 140 systolic. We're not talking about diastolic, obviously, but if they tolerate very well, they are very well preserved. Probably going 130 or little below would be reasonable. Indapamide has tried in HIVET study. And of course, a cocktail was tried in Sprint trial. Obviously, the drugs which I would avoid in an elderly hypertensive, or let's say systolic hypertensive individual, would be beta blockers. And I would avoid actually stronger ARBs, more so olmesartan and azilsartan. That is what my gut feeling. But otherwise, I would use anything and everything. Thank you, gentlemen. I have been asked actually to that should be the last question, because we have gone overboard, and I take this opportunity to express my deepest gratitude, starting from Dr. Rath, Dr. Jay Shah, Dr. Tom Devasia, and of course, my dear friend, Dr. Rajiv Gupta, without whom we would not have got that kind of information. And Rajiv, thank you. I am happy to see you again.
Yeah.
And see you in the future. With those words, I would pass on the baton to Amit.
Well, Dr. Mohan, I have got a question. I have got an answer from all of you here.
Yeah.
Can I put it?
Yeah, please go ahead.
You see, the office BP often are the so-called white coat effect. Many times we come across. Now, many patients we see, the moment we see the record the blood pressure, even with a gap of some time, 2-3 record, all the times it is high in the office, and we ask the patient to have their home recording, it is less.
Yes.
The question is, the BP variability, 24-hour BP variability is also applicable to this point, because when it comes to the doctor's office or any other office, also patient might be experiencing a higher recording. So anytime a higher recording BP variability is higher, that needs to be addressed. Now, what should be the real drug to treat that sort of patient? Is it suppose they have got an associated sympathetic overactive features without any hyperthyroidism, is there a role of a beta blockers there?
So that's $1 million question for which there is no answer. We know that white coat hypertension increases the risk by average 35%, sustained hypertension about 100%, and mask hypertension in between about 70-75%. Although Tom showed a data which showed mass hypertension having more risk, but Dolan's data, which is of 12,000 patient ambulatory monitoring, 11 years follow-up, has shown that mass hypertension falls in between sustained and white coat hypertension. Having said that, you are absolutely right. We see a lot of that difference. Sometimes, in fact, there is actually a intra-arterial blood pressure monitoring study which has shown that the moment the patient is in ICU, the moment doctor comes to his bedside, the blood pressure shoots up as much with the average of 23 millimeter increase in systolic blood pressure, but some had as much as 70 millimeter increase in systolic blood pressure. So white coat hypertension is a real phenomenon. Your question, how to treat it? I don't have an answer. Should we treat with beta blockers? We have no evidence. Do you do it? Well, I don't do it at this moment. If there is some iota of evidence, I'm ready to do it. I'll ask Rajiv and then, of course, Tom. Rajiv?
Yeah, I think white coat hypertension, again, we are still learning about it. So we really don't know about the white coat hypertension. We really don't know about the stress-mediated hypertension, which is a variety of white coat hypertension. And there are no large trials because it is almost impossible to do trials, large trials in people at very low risk. So I think the question still remains open, and I think we'll have some data as time passes.
Your view on white coat hypertension?
Well, to the question, do I give beta blocker to people whom I suspect white coat hypertension? Yes, I do.
To some of the younger people who have inappropriate sinus tachycardia, hyperkinetic circulatory state, I probably would give it. Some of these guys, but by and large, actually, I yesterday saw a friend of mine. He's 61 years, very well established in business, no problems, kids married off. He's on 5 anti-hypertensive drugs. Now, every time he comes to me, I measure blood pressure 190/90. I put him on ABPM. The blood pressure is little high. I would say the average blood pressure about 140/85 is not too bad. I know it should be better. It should be 130. But he's already on 5 drugs and he has no target organ damage. The question is, he has already 50 millimeter difference. So am I going to give him beta blockers? Will it help the 61-year-old man? I don't know. I have no answer to that.
But do you think that, sir, in such type of scenario, is it better to look for the sleeping pulse rate of those patients and those who are having some inherent sympathetic overdrive or overactivity, as it has been shown in Indian heart study that the average heartbeat of an individual which was being studied, like the number of patients which are being studied is 18,000, where the white coat hypertension was being detected in 18% of the patient, and mask hypertension was being detected in 24% of the patient, where the mean heart rate was remaining 81.3 beats per minute. Now that is more than the 70 limit what we need to treat. Like we always keep the heart rate of less than 70. So the heart rate variability itself is another topic along with BP variability. So I think...
so Jay, since I am one of the authors of the paper, let me correct first facts. The facts are mass hypertension is there in 18%, not 24%.
Okay, it's reverse.
Hypertension first visited 24%, the second visited 12%. So I thought I just correct you. And the third thing is average heart rate is 82. And the fourth thing is evening blood pressure higher than morning blood pressure in India.
Correct.
The 4 major things. But the point which you have is very valid. Should people who have a nocturnal high heart rate be given beta blockers? I am not aware of such a study having been done. It looks a great hypothesis. Maybe Rajiv can do something about it. One of these days he decides I'll do, but he needs to get some sponsor, somebody who will pay money for it. It's not going to be that easy. But just the answer can come. He's the guy who can carry on this study for 5 years, collect 1,000, 2,000, 5,000 people, or somebody has to pay him.
I'm sorry about the fact, sir. It was actually a reverse.
Yeah, that's no. I thought I will do it. See, the thing is, when somebody makes you an author, you read that bloody paper 10 times, so that you don't make a mistake in quoting it. You make a mistake in quoting it. That's a big problem, actually.
I know.
So thank you, Amit. Where are you? Mithlesh, where are you? Mohit, where are you?
I'm here, sir, and listening to this interesting discussion which is happening, and I must say thank you to you. You bring so much of liveliness in the whole program with your presence, and as people always say that you are the encyclopedia in whatever topic we discuss. And thank you very much for being the guiding light in the practice pulse and hypertension. We are coming to the end of this 9th edition of this program, which we do second Saturday of every month, and we continue to do so in times to come. I must thank all the delegates who have joined in from all over the country. We had almost 800 registrations and we had live audience today. And there were a lot of questions which were being asked, although some of them were general questions, but there was a lot of interest. I must say thank you to Dr. Rajiv Gupta for taking his time off and coming to this digital podium and delivering a masterful talk. I would thank Professor Tom Devasia for accepting the invitation at a short notice. And thank you very much for presenting your cases. I must thank Dr. Praveen Rath, Professor Praveen Rath, for bringing that liveliness in the panel discussion, and Dr. Jayasha. So once again, at INTAS, we thank you all for joining in today. And we have our antihypertensive portfolio, the calcium channel blockers, Cilnidipine, and MTAS-M and MTAS 80, both are available. So thank you very much once again from here at INTAS, and good night to all.
Thank
you. Good night.
Thank you.